after Anita welcomes everybody, Anita will usually go to our chief nurse because patient experience and patient stories sits, as we said, in the chief nurse's portfolio. So that will be Sue Smith today. And Sue may say a few words, but we'll probably quite quickly hand to you to share your story. And you have the floor. And then we have about 10 minutes. And then we'll go back to Anita, who will have a conversation with the board and invite people to have a conversation, and may well bring in Emma or not.
Absolutely. The only addition I'd add to that, Anna, is Sue and I chatted day before yesterday, and she was asking me, and I said, "Oh, hand over to Anna." I said, so she may come to you first, but for you to introduce Glenn is maybe what she does, but just for your information.
Happy with anything.
Okay.
I missed the beginning of that, Anita. What am I doing?
Oh, you're not you. No, sorry, Sue Smith, not you.
Oh, fine, Sue Smith. Great.
Yes, no, not you. Don't worry. Yes, basically, you're leading the board today, Sue. Anyway, right. Let's see. People are still coming in. Good. Rebecca, did you say that Richard will let you know when the stream is live and we're good to go?
I do hope so. I will just go and run and ask him. Bear with me. I can see his name, but I suspect it's his YouTubing computer. Bear with me.
Yeah, thank you.
You are a truly wonderful human being, as are the three crack IT team members who've just got us back on the internet. Thank you so much. All right, bye-bye.
We'll tiptoe quietly backwards.
Yeah, don't touch any floats or anything like that.
Over my phone.
Morning, everybody.
Morning, Matthew.
Morning. Good morning.
Hi, Chair. Just to confirm that the YouTube link's live.
It's live. Brilliant. Thank you very much. We've got a couple more minutes. Oh, here's Joe.
Oh, heavens.
Good morning, Joe. Ringshall,
Morning,
that is.
Lisa.
Good morning. Joe, just to let you know in advance, when we get to a particular paper that we've been having discussions about up till now, I think we will as a team try and address your questions in advance. But what I will do is at the end of that, if there's anything that is still not clear or you still wanted to raise, I will ask you for a comment straight after that paper rather than at the end, if that's all right.
Great, that's very kind. Thanks, Anita.
Great. Okay, let me see. We have... Is there anyone that we would be expecting? Let me think. Is Matt Howells here? Can't see him at the moment. So, Christine, yes. Oh, there's a few people missing at the moment, but okay. And just as a reminder for everyone, if you're not speaking, if you could go on mute, please, just to try and limit background noise, that would be helpful. Thank you very much. I can hear a little bit at the moment. Right, I make it 10 o'clock, Rebecca. Are we okay to go?
Yes, Chair, chorus and able to proceed. Thanks.
Brilliant. Okay, so good morning, everyone. My name is Anita Day. I'm Chair of Worcestershire Acute Hospitals NHS Trust, and this is the meeting of the board in public on Thursday, the 8th of June, 2023. I'd like to welcome members of the board, our guests today on Teams, and indeed those patients, staff and other interested parties who may be joining us via YouTube. I hope you're all well. We have apologies this morning from Jackie Edwards, our chief nurse. We have one of our deputy chief nurses, Sue Smith, will be deputising for her today. Welcome. And I'd also like to specially welcome Sarah Shingler, who is our chief nurse designate, who's joining us today. Before I go to the patient story, it is my custom to talk a little bit about our values, our purpose, and so on. And as you know, at the top of our strategic pyramid is that purpose about putting patients first. We've talked in the past about what that means, but one of the things that isn't actually explicit in that, but actually is absolutely implied, is that if we're going to put patients first, it's all about treating every patient as an individual, as actually recognising that what works for one person may not work for another, and that sometimes the first plan of care we have may not be the right one, and we may need to adjust it and change it to make it more suitable for a particular patient's needs. Today's story is an example of exactly that, and therefore I'd like to hand over to Sue Smith to introduce us our story. Thank you.
Thank you, Chair, and good morning to everyone. Also welcome to Glenn Adamson, who's here to share his story with us this morning. I'd also like to welcome Emma Davis, our alcohol liaison nurse who works at the Alexandra Hospital, who's also here to support Glenn, and obviously Anna. Thank you for attending as well. I'm sure we've all had a busy morning, but as Glenn takes us through his story of his care through our trust, the request is to put all that aside and listen with fascination. I think as Anita's introduced as well, I'll not say any more now, but the story will tell itself. So now I'll hand over to you, Glenn, if you'd like to take us through your story. Thank you.
Hi, good morning all. Thank you for having me. I do appreciate it. My background is law, and it's a very pressure job, as you can imagine. And I went more towards drinking and excessive drinking to the point that it become unmanageable. And I was missing days off work because of drink and one thing and another. And I just one day I just couldn't see any way out of it other than, just to end things and, put a complete end to my existence, really, which I found extremely hard and challenging. But, when you're in that kind of position, you don't see a light or help in any given shape or form. And from what I can gather, I was admitted to hospital through an internal overdose, through drink, and goodness knows what else. And I believe my first encounter with Emma, I didn't even know. I didn't even know she was in the room. And it I was kept in overnight. And they monitored me. And within a week or so, my GP, who I now know extremely well, he's an army medic, Dr. Jonathan Leach, and I reached out to obviously my local GP was regarding this, and he recognised me because I'm a military veteran, and I was in the Paris for 7.5 years. So he reached out to between himself and Emma, Emma then kind of contacted me and asked me if I'd like to attend. At that time, I became a bit of a recluse. I would only go out during the evening, during the dark, just to hide myself from other people, because obviously it was a shame thing because of my background, where I'm from, and showing any kind of weakness is not tolerated. But I kind of, my first encounter with Emma was very kind of earth-shattering for me, because everything kind of, you know, we spoke about, she reached out to me and, you know, said, look, you know, it's going to be a tough road. And she put it on a plate. You know, some of it was rather hurtful, pointed, but, you know, it was necessary. And I'd done a week of treatment with Emma. And every day, you know, that I went there, it was a struggle. It was a complete struggle, you know, to the point that I couldn't even trust myself to go there. So I was having friends. I don't have any family. You know, I don't have an next to kin. And my friend was dropping me off at the hospital, making sure I was getting there. Emma was in close contact with my friend, you know, and throughout that whole week of journey, you know, you can imagine there was tears, there was upset, you know, but throughout it all, I knew that, you know, if I failed, I would not only fail myself, but I'd fail Emma in what she built up. So I went through the week of treatment in and out the unit. I was then put on medication, which Emma, bless her, you know, so I mean, all that aside, you know, from where I am to where I am now, it was the support that I had from Emma. You know, it was, you know, daily contact. If it wasn't by email, it would be, you know, I would go into the unit, you know, and when I was kind of, should I say, released into the wild, Emma was the only one that kind of said to me, you know, you can come back, you know, my door's always open, blah, blah, blah. I went to a support group called Cranston's, which I found not very helpful. This is run by all sorts of walks of life, to the point that the gentleman that I was, or should I say, acquired or saddled up with, wasn't to my needs. Now, I relayed that to Emma. Emma then said, fine, if they're not happy with it, you know, you're more than welcome. And Emma took me on board, and I went through Emma for my support, albeit she went above and beyond what I could ever imagine. And it was like it became a weekly occurrence where I'd go in and she'd kind of talk me through, you know, and she kind of reprogrammed me mentally and physically, reprogrammed me. You know, it was kind of a different way of thinking, a different way, approach it in this way. If, you know, get out of that habit, try and, you know, it's like smoking, you know, it's like, you know, you go out, you walk out the door, you go to the paper shop, and it was just, my mindset was completely reprogrammed, where it was to the point, go a different way, walk a different way. That'll get you out of that mindset of, you know, going over to the road and buying some beer and, you know, go a different way, walk a different way. It was all, my mindset was completely changed. And week in, week out, you know, Emma would kind of take it upon herself. She'd email me, and the support that I had was absolutely phenomenal, where it become every 2 weeks. And it would be like, you know, and every day that I walked in, even the nurses on the unit, you know, they'd sit with you, albeit they didn't have any interaction in your medication or your treatment. you know, they would sit next to you and say, how are you? How's things? What are you doing? You know, and take that time to kind of like, you know, relate to you, irrespective of whether or not, you know, you weren't, you know, sort of part of their course or treatment, or, you know, every one of them in there, you know, even to the point where it become fortnightly and then it became monthly. And, you know, they were saying the change and the you know, that I've come from and where I was. I mean, I don't even recognize myself. And, you know, it was like, even now, you know, my whole life is kind of, Emma has given me back my life. That's all I can say. You know, I look at things differently. I've gone, you know, I was employed. I was off work for almost a year. I'm back at work, unfortunately, as you can see. And everything that Emma did, support, verbally, mentally, physically, you know, if the NHS could bottle that and kind of distribute it throughout the whole of the UK, you know, I think the world would be a fantastic place. Because, you know, I can't honestly thank Emma enough for what she's done. And you know, I do owe her my life for what she did, because she gave me back my life. Now I haven't had a drink. I can't even remember. You know, I'm back at work. I work in law. You know, I'm back in court doing things that like normal run of the mill. You know, I go out, I socialize now. You know, before I was a mere shell. And even now, you know, I'll get the occasional contact from Emma. How are you? How's things? You know, and you know what? It's just tremendous. That service that they provide, that small unit. It's a shame that we couldn't, you know, split it over the whole country, because I think people are starving of that need. People, you know, crave for that, and I'm just, honestly, I'm absolutely stuck for words for what she's done for me. And you know, I've been to Sri Lanka. I was over there for 5 weeks. You know, it's like I never thought I'd be doing this again. You know, like back in my life. You know, and even now to the point where, you know, there's meetings at our local church for the AA. You know, they've kind of said, why don't you become a support worker? You know, I'd be more than happy to be an advocate for the service that Emma had provided. You know, she just absolutely reprogrammed me completely from top to bottom. And, you know, and I can't thank her enough.
Glenn, that's wonderful. And I know how difficult it was to tell that story. That's lovely. Anna, Emma, anything you want to add to that?
Yes. Can I firstly thank you, Glenn. It's the biggest gift really is seeing that you've moved on with your life and you're doing so well. Excuse me, I'm a bit emotional. But really, Glenn, it was about you. You, a person needs to want to take that path, be willing to try different ways. So, I mean, I'm feeling a little bit overwhelmed with your gratitude, but really, you did the hard work. I just sort of kind of facilitated some of it. So it really came from you. That's kind of all I wanted to say. Thank you.
No, thank you, Emma. And I truly, I'm really indebted for what you've done.
Lovely. Anna, Sue, anyone before I open it up? Simon, yes, let's open it up for comments then. Simon.
Thank you, Glenn, and thank you, Emma, as well. It is a wonderful story, and Emma's quite right. It's down to you, Glenn. It's what you were doing. But for me, as a member of the board, I don't feel ashamed to say I wasn't really aware that we had a unit like this and what it was doing to people's lives. So, Emma, perhaps you could just tell us a little bit more about how the team works, how big you are, aspirations for the future, those sorts of things. I know we haven't got limitless time, but I'd be genuinely interested and obviously so impressed with what you do.
Okay, so basically, I've been the alcohol specialist nurse in the trust now for almost 13 years. And it was really to try and be a bit more flexible with the service. I come from a community background, and running detox services was my sort of bread and butter, really. And I think as I developed really good relationships with some of the nurses, and I think it was around the time that ambulatory emergency care was really starting to get off the ground following the Whittington model. And the team were just really proactive. And I suggested that, you know, maybe we could try doing something like this, and that I would, you know, potentially lead and support the team. I would need their support in terms of obviously staffing and providing a place for me to see patients. And it's just really grown. The team is me, unfortunately. We're looking at how we can take it over to Worcester Royal. But again, there's only me. There's only one alcohol nurse in the trust at the moment. I am looking into developing the team because obviously if there's more of me, then we can provide the service to more people and identify more people. I mean, Glenn rightly stated earlier, there's a lot of stigma around alcohol problems, drug addiction. And even in the hospital, I see stigma all the time. You know, it's about trying to address those opportunities for everybody, those health inequalities, really. And I think in a lot of hospitals across England, alcohol care teams, where there are 6 or 7 nurses just doing alcohol work in an acute hospital. And I think that's something that I feel that, you know, I'd like to aspire to, really. So that's a little bit about the unit and what it does.
Thank you, Emma. Christine.
Thank you for telling your story, Glenn. I'm a gastroenterologist, so in my career, I've looked after a lot of people with alcohol-related problems, and I think what came across really strongly in your story was the shame that a lot of people with alcohol dependency feel, and what I have observed sometimes is the stigma that Emma describes, and I have sometimes found other healthcare professionals, medical, nursing, therapists and so on, stigmatizing patients with alcohol dependency and not treating them as well as they should. And that's why I'm delighted to hear that you've got such good care and treatment here, because it is not universal that patients experience that. So it is really good to hear. And Emma, I would completely support your ambition to have an alcohol care team. I think given the prevalence of alcohol dependency in our population and the size of us as an organisation, I think that is something that we should definitely have.
Thank you, Christine. Emma,
can I just say, yeah, there was a recent report from King's College that suggests that 1 in 10 patients in our hospitals is alcohol dependent. So that's a lot of people. Absolutely. That we're not seeing or supporting.
Thank you, Emma. I don't see any other hands up. Glenn, did you want to say something?
I do think that there is a need for this, and it's a massive, you know, particularly in this day and age with the pressures, mental health. You know, the first thing people lean to is a crutch that they have, which is alcohol. Yeah, everybody's ashamed. I was so ashamed of myself. I couldn't even look at myself, you know. And now it's like, you know, I'm a totally different man. You know, I actually speak to people, like I say, at the AA meetings, and I've got people phoning me and saying, "How did you get over it?" You know, and I'm now, the skills that Emma had given me, I'm now using those with other people. And you know what? It's tremendous, honestly. And I just think, you know, if we had 2,000 Emmas around the country, I think the world would be a better place.
That's lovely, Glenn. I don't see any other hands raised. So, I mean, just to sort of wrap up, I mean, first of all, as I said at the beginning, thank you so much. As everyone has said, you know, this is a difficult issue to talk about, and to talk about your own personal experiences. This was not easy in a public forum, and we are so grateful that you did take the time and were willing to talk openly about it. Obviously, we are immensely proud of the work that Emma has done with you, and as others have said, it sounds like this is something that we really should be looking at expanding in the future. But as also, as others have said, at the end of the day, this was about you and your recovery and your getting your life on track, and massive congratulations from all of us to you and what you have achieved. And it's you know, some of the phrases you used were it was lovely to hear. So very well done, Glenn, on everything you've achieved. It sounds like you've done fantastically, and our very best wishes for the future.
Thank you ever so much. Thank you all.
Thank you, Glenn. Bye-bye.
Bye-bye.
And thank you, Emma and Anna. If you want to drop off now, that's absolutely fine. Thank you very much. Right. Lovely story. Let's then move on with the formal part of our business. Have any items, any other business, has anything been notified to us? No, I get a nod, a shake of the head from Rebecca, so I'll assume not. Declarations of interest. Obviously, our normal ones are on the website, but are there any specific declarations that anyone needs to make in connection with today's agenda? If you could let us know about that now. Again, I don't see any hands raised. So let's move on then to the minutes of the previous meeting on the 11th of May. They're in our packs. Could I ask for any comments or amendments or clarifications that are needed on those minutes? They're very lengthy. I don't see any hands raised. Yes, they go up as far as the end of page 12 in our pack. If there are no comments, can I take those as a true record of our last meeting, please? Thank you very much. Okay, action log, Rebecca.
Yes, thank you, Chair. The action's been updated as per the log, and as discussed previously, we're in the process of reviewing the board development plan. Thank you, Chair.
Brilliant. Thank you very much. Any comments on the action log from anyone? Nope. Okay, let's move on then to the Chair's report, or rather we won't. With your indulgence, I'd like to take that at the end of the meeting, please. So I'll move straight on to the Chief Executive's report. Matthew.
Good morning, everybody. Thank you, Chair. I'll assume colleagues have read a slightly shorter Chief Executive's report this month, not suggesting I haven't been busy and doing lots of important things that chief execs do. Just draw a particular note to a couple of the points. For a number of us attended our first Wellbeing Matters Day in May, well attended by many of our staff, a good cross-section of staff from all our hospitals and all different roles. And I think it was a really important exercise, an opportunity to really build on what is now an award-winning health and wellbeing offer, and really engaging, listening, learning and leading by engaging our staff in understanding what next. It's always a life's work to continue to build on a health and wellbeing offer as the conditions and circumstances that our staff working across the NHS changes and develops. So looking forward to the organisation continuing its journey in relation to building on the health and wellbeing offer that's already in place. And thanks to Tina and Richard and others that were instrumental in putting that session on, which I know was well received by our staff. The the wicked issue for us as an organisation, as we know, over a number of years now, has been the urgent and emergency care flow challenge in making sure that beds are available in our hospitals at the time they're needed for emergency patients. And we're in the process now of rolling out some of our forward improvement system changes that our staff have developed around electronic patient record and tablets to take home processes. So we do anticipate that's going to help to, if you like, bring the most likely time of discharge for our patients from our hospitals earlier in the day from the peak, which is around 6 p.m, particularly on the Worcestershire Royal site. So more on that, I'm sure, later in the meeting. And then finally, just to draw attention to the draft joint forward plan that across the integrated care system is being developed. And I suspect more on that in future meetings where we'll be asked to consider, contribute and make sure that we feel that it's in line with our existing purpose, as Anita said earlier in the meeting, of putting patients first, but also our focus on making sure that we are both working within the integrated care system, but providing alongside that exemplary secondary care services. And then a final plug for our charitable event in the Malvern Hills this weekend. Get your boots out and your sun cream and your hats, and for some of us maybe a walking stick. And I hope that's successful for our building our charitable funds, and therefore the great work that our charity does for our patients and staff. Happy to take any questions, Chair.
Thank you very much, Matthew. Any questions or comments on any parts of Matthew's report? Simon?
Not on the walk. I'll tell you about it afterwards, if I survive. It's specifically on the rollout of Forward, Matthew, which is good news on the electronic discharge summaries and then the TTOs as well. What monitoring sort of mechanisms we've got in place? When will we see the outcomes and know that this is actually working, that we can sort of report a before and after, which would be good to know?
Yeah, so there's clear metrics that are assigned to each of our value streams and each of our elements of improvement work. Essentially, we've been piloting and doing a proof of concept in one of our medical wards, our short stay medical ward on the Worcester site over the course of the last month or two. We're then going into the process of then expanding that into two of the Aikenbury wards, Aikenbury 3 and Aikenbury 4, if you like, as a pilot. Similar, actually, Simon, to the way in which we rolled out the electronic patient record. And then the full, if you like, rollout across the sites is when we'll see the biggest benefit, because obviously what we want to do is build from the proof of concept success through the pilot, learn from the pilot, and then expand it further. So I would say it's going to be, you know, a number of weeks, but clearly we've got to move quickly on this because there is an urgency each day to make sure that our patients are safely discharged. But we've got clear metrics which we can share in more detail as we do the briefings.
Thank you, Matthew. Richard.
Thanks, Chair. And thanks, Matthew. On the 5-year plan, did we have any input into the 5-year plan? And what are the specific next steps, or can you not say more about it?
So I'll bring Jo in because Jo's, in the context of her role as Director of Strategy and Planning, been instrumental in working with the ICS and ICB leadership team on this. I think there's certainly a need for us to contribute quite significantly, given that we're the biggest organisation in the integrated care system, and therefore what works and what our successes essentially mean the successes of the ICS plan, although there is inevitably a demand on the timetable for submission that is driven by national timetables. So there's a tension there between, you know, fulsome input at this stage and timetables for submission. But Jo, is there something you wanted to further add?
Yes, thank you, Matthew. So the 5-year forward plan needs to be submitted to NHS England. We've been contributing in terms of developing the plan with the other directors of strategy across the ICB. And I think it's fair to say it is in line with our three-year plan and our strategic vision. There is further work that needs to be done just in terms of developing as part of the work we're doing with the medium-term financial plan. And for that reason, we would want to bring back a bit more of a fulsome plan that identifies some of the milestones that are needed to achieve that 5-year ambition as we work through the summer, which is what's detailed in the Chief Exec's report. So I'd propose that actually we bring that back as a appropriate board development discussion before that decision needs to be made.
Thank you, Jo. Did you? Yes, you've taken your hand down. Thank you. Just going back to the point about the forward improvement system, I think that just for board colleagues, we are actually planning a board development, I think, in a couple of weeks, which will be focusing on things like the forward improvement system, about tracking progress and so on. So hopefully we'll be able to explore that topic in a bit more detail at that time. I don't see any other hands raised on your report, Matthew, so thank you very much. We'll take that for noting. And let's move on then to the communications and engagement update. Richard.
Thank you, Chair. Good morning, colleagues. Again, take the paper as read. Matthew's already helped me out by highlighting one of the items I would have drawn attention to, which was our very successful Wellbeing Matters Day. A plug, given that we are live streaming this board meeting for the staff awards, which have now been launched. Entries are open, and this week we started doing some additional publicity through the media and social media to encourage public entries to the Patient's Choice Award. Last year we had nearly 1,000 entries, and we've got off to a strong start this year, but would encourage all board members to think about if there's any colleague or teams they would like to nominate, and get those nominates in the most timely way you can. We've also had encouragingly strong levels of interest in the sponsorship packages, and colleagues will remember that last year we managed to cover the cost of the event through sponsorship managed by the charity team. Will be a lot of work, but I hope that we can deliver an event in November that is at least as good as, and hopefully even better than last year's spectacular. So that will be a key area of focus. Matthew's also mentioned the Malvern Walk, but in terms of other new things that we are doing through the charity with comms support, draw colleagues' attention to the final item for the fundraising appeals to support the emergency department development at Worcestershire Royal. And again, these are a couple of new things that we've never tried before, which is a door drop fundraising campaign that is due to start early next month, that we will support through comms to give people a chance to contribute to some finishing touches to the department over and above the core NHS offer, and also a number of other fundraising campaigns that are designed to further enhance that important development, improve patient experience, and improve the lot of the teams that we know are working so hard in those services. Finally, I think it's only 3 paragraphs of the report, but I wouldn't want colleagues to underestimate the scale of the work that is going to be required in moving us through the rest of this year to a new intranet, which we are bringing in-house and hoping to manage through Microsoft SharePoint to enable better integration with other internal communication systems. That will be a major piece of work. And with challenging timing, we've also had to manage moving to a new content management system to our externally facing website. So again, that will be a significant amount of work. I hope that in 6 or 7 months' time, we'll be able to show colleagues a greatly improved intranet, which will hopefully improve access to important information for colleagues across the organisation, and an internet which is an even better shop window for the trust and everything we are doing. The only other item that I would have drawn attention to, Chair, is the communications around the board succession planning, but I'm going to come to that during our discussion on that particular board paper. So pause there and happy to take questions.
Thank you, Richard. Any questions or comments on that comprehensive report? Richard.
Thank you, and thanks, Richard. And clearly some really good work, and we cannot underestimate the importance of communication. You also mentioned you've got finite resources, so you need to make choices. And I was wondering, do we have any idea of how we benchmark against others in terms of the size of our communication capability?
It's very difficult, Richard. There's no standard recognised model for communications teams, and certainly talking to colleagues in the region and further afield, the range of activities and responsibilities taken on by communications teams varies widely. I think I've said to board meetings before that I would never turn down more resource, but I also recognise that we are relatively fortunate in this organisation in where comms sits and how it's resourced. It's not universal, for example, for boards to have a communications director sitting in the position that I'm in, and that says a lot to me about the commitment that this trust has made to communications over the years, and the level of support that board colleagues have given to me and the work that we do. I think it would be fair to say that compared to some, we are relatively well resourced, but it is very much a function where success breeds success, and we have seen demand for what we do go up, particularly in areas like graphic design and most especially in video, and that's a real video production and editing is a real pinch point for me at the moment. We're trying to address that by not relying on a single member of the team, but by skilling people up. And we are also looking at how, and we discussed this at Transformation Guiding Board yesterday, what we can do in other parts of the organisation to give other colleagues those core skills that would enable them to produce their own content. And we have made a little bit of progress on that, although not as much as I would like. The other part of it that we have moved to in the past probably 18 months is, as part of the business planning process, when major programmes are coming up, building into those funding for communications capacity. And that's how we've secured additional capacity in the team to support the EPR and the forward improvement system. So I'm not complaining, but neither am I saying I've got more than enough.
Thank you, Richard. Matthew.
Yeah, thanks, Chair, and big thanks to Richard for his he and his team's great efforts and offices. And I just wanted to draw attention to a couple of points. For me, when I joined this organisation, it was really positive to see that there was a communications director in the executive team sitting at the board table, because that is essentially if really the organisation means business about involving, engaging with its staff and its stakeholders. So I would commend that as the right model for any large organisation. I do, though, think there is a tension, and Richard's alluded to it a little bit, between having a really competent, proactive communications team and the risk that, therefore, others absolve themselves of their communication responsibilities. And so it is really essential, and draw attention to the conversation Richard alluded to at the Transformation Guiding Board yesterday about the responsibilities of every member of the organisation, particularly in a leadership role, to communicate, to engage, to listen, to learn, to lead their teams. And I think that's still a journey that we're on as an organisation. I think we've made great strides, but it's not all Richard's responsibility and his team to get communication right in the organisation. We know day to day some of the things that cause difficulties for our patients and frustrations for our staff are a lack of communication. And so I'd, whilst really positive reports come into the board, I think there's also a line of questioning for us to continue to ask around the responsibilities of middle managers, clinical leaders and others around communicating, listening, learning and leading their teams in a proactive way. Thanks, Chair.
Thank you, Matthew. Tony.
Yeah, thanks, Joe. Just a minor observation on the comment Richard made about the video production pinch point. I've had direct experience elsewhere of trusts making contact with their local FE, further education colleges, and their media studies departments, and their students coming in who are looking for the experience of making commercial style productions and using that as effectively a fairly free resource, which is beneficial for both parties. Just a suggestion it might be worth exploring here. Thanks.
Thank you, Tony.
Yeah, thanks, Chair. We have got a couple of examples where that's happening, Tony, where particular pieces of work for teams that we would not have the capacity to do are being done, but under the stewardship of my team to make sure that if anything's going in the public domain, it is consistent with the kind of messaging that we would want to be sharing about the organisation. But I think there is potential to do more. And I also think certainly through the Place comms cell, which colleagues may be aware that I chair, I think there is an opportunity for us to look at some of the public health campaigns, some of the messaging around the winter campaigns, some of the awareness around raising awareness of alternatives to ED, that we could use that resource most beneficially, not least because you are then engaging people who are drawn from the demographic that you're trying to reach out to. So it's a kind of win-win that we get the free resource, but we also get people from groups who can bring that perspective and say, well, that I wouldn't pay attention to that message, or I wouldn't look on that platform. So, you know, I'm old, so I use Facebook. We're also looking to reach out to people through Instagram or TikTok or other channels. So I think the more that we can take advantage of that, the better, as well as then enabling those people to develop their own skills in a fairly challenging and complex environment.
Thank you, Richard. Any other questions or comments on Richard's paper? I don't see any other hands raised. Thank you, Richard. I think it's a really comprehensive sort of school report, and for me, I think that the important bit is, and it's in the title of the paper, it isn't just about communications. What this is actually about is about engagement, and that engagement both internally and externally are vitally important to us on the journey that we're on. So thank you to you, Richard, and the team for your work over this period. So thank you.
Thank you, Chair, and I, as always when I present these reports, this is very much a team effort. You know, I'm standing here sharing with you the outcome of a lot of hard work by people in both the communications and charity teams. So the credit goes to them.
Absolutely. Thank you. Right. So if there are no other comments on that paper, let's move to the next item on the agenda, moving forward on Foundation Group membership. Matthew, I'll hand over to you.
Thank you, Chair. So I think make some introductory comments to this paper and then hand over to Joe Newton. Joe Newton is our Director of Strategy and Planning to take specific points to draw out from this paper. I suppose by introduction, you know, the organisation has benefited from quite stable board leadership over the past 5 years, and I think has overseen some great progress in a number of fronts over that period of time. We know that exiting quality special measures, delivering on financial targets over recent years, improving our patient experience has all been really important and recognised, whilst at the same time we've got some wicked issues that we continue to grapple with, particularly, as I mentioned earlier, urgent emergency care and the recovery after the COVID pandemic. And in terms of that stable board leadership, obviously my imminent departure and Chair, your term of office coming to an end during the summer has raised for us as a board, I think, and rightly so, a question of what should our future organisational look like, in order that we're able to continue to put patients first and to work closely and listen, learn and lead with our staff and stakeholders. So we've taken a view, I think, and that's articulated in this paper, about the direction of travel across the NHS, with providers working more closely together. This term provider collaboratives has become more important, particularly working across geographical areas. And we'll remember that the Midlands was historically divided into different areas, and working closely as we have been with colleagues in Herefordshire and Warwickshire and Coventry and Birmingham, has, I think, raised for us the question of what's the right direction to travel for the next period and chapter of Worcestershire Acute Hospital's history. And of course, we've been in a relationship with our neighbouring trust as an associate member of the foundation group. So one of the things we've looked at, which is described in the paper, is whether there is further development of that relationship that would be a benefit to our patients and our staff. And that's what's articulated in this paper. And I think as we consider Joe's comments and then have the discussion, I think it's right and proper that we have in our back of our minds Glenn's story of exemplary care in the most difficult of circumstances for him as an individual, and the way in which our services are responsive, and thinking about how we consider over the next, now, as I said, chapter of the organisation, doing the right thing for our patients and for our staff. So I'll hand over to you, Joe, if that's okay, to draw out some key points from the paper, and look forward to the discussion. Thank you, Chair.
Thank you, Matthew. And just to reiterate some of the points that you've made. So this paper really seeks to address and bring together two aspects of work, one of which is that succession planning for our chair and chief executive, and secondly, building on a trust board paper that actually came in April, which rehearsed some of the provider collaborative developments. And in that, the question we're trying to answer is actually, how do we achieve a stable transition to allow us to continue to put patients first and to deliver on our strategic objectives, and that's both in the short and the longer term. So as Matthew's outlined, we have had a relative stability as a trust over the last 5 years, and I think it'd be fair to say that the introduction of putting patients first and that strategic pyramid has really given us the foundation by which we've both launched the Forward Improvement Programme and made significant improvement in our organisational culture and journey. There's also a lot of progress